live in 3, 2, 1, 0.
Welcome to the Heart of Innovation, 60 minutes that could save life and limbs with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global P.A.D. Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global P.A.D. Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the Heart of Innovation. Today, we're talking about a silent killer, a genetic marker called lipoprotein little a, or LP little a, that can significantly increase the risk of heart attacks and cardiovascular disease. LPA affects 1 in 5 people worldwide, yet most don't even know they have it until it's too late. In fact, LPA can increase heart attack risk by 2 to 5 times. And many don't know they have it until it's too late, unfortunately. But there may be hope on the horizon. New drug trials are underway that could help address this overlooked condition. And joining us today to discuss what we know and what we don't know about LPA is Dr. Harpreet Bhatia, Associate Professor of Medicine at UC San Diego's in the UC San Diego Health System. We also have a couple of patients here that are going to share a little bit about their personal journeys with LP little a. Before we get started, of course, let me welcome my co-host, Dr. John Phillips. Hi, John.
Hi, Kym. How are you? Happy Saturday. I'm really looking forward to this conversation. Dr. Bhatia is a preventative cardiologist. I'm an interventional cardiologist and kind of by definition a reactive cardiologist. And so I'm really excited to have a conversation, not only about LPA, but also just in general cholesterol, kind of what we should be talking about, not only as physicians, but patients, and how we can mitigate our risk for developing atherosclerosis, which is the number one killer of adults in Western civilization. So he's written a ton about this, and he is an expert on LPA and an expert on cholesterol as well. So I'm really going to pick his brain. I'm going to put my thinking cap on as well. So this is going to be a tough one for me.
No, but I love that you're so interested in this topic and the fact that you want to learn more about this so that you can bring it back to your patients as well to help you in your practice. And I think that that's incredible. So let's dive into the conversation. But first, we always get started with a moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
So again, real quick, I don't want to derail from the conversation, but this morning I was doing marketing for Game Day, our men's health clinic in the area, and OSU's playing Nebraska, so we were at the OSU tailgate, and I couldn't help just be in awe of the amount of security that exists there. And I ended up talking to multiple law enforcement officers and just kind of just talking to them about their process of making OSU Stadium safe. And I was just in awe of these guys. And so I found a quote from Ronald Reagan, who basically it kind of reflects his admiration for law enforcement. And he basically said, evil is powerless if the good are unafraid. And these guys are unafraid. They had a truck there that was riddled with buckshot. It's like this massive SWAT team thing, and it had buckshot on it. Like one of the windows they tried to shoot out. So these guys put their lives on the line every day. Kudos to them. And just proud to be able to speak with them this morning for game day. So anyway, that's my moment of inspiration.
And I'm going to apply that to the medical system. And when good people like you and Dr. Bhatia from UC San Diego Health System are on the prowl for cholesterol, I think that the evil cholesterol stands no chance against good people like you guys.
Well, yeah.
Did you like that?
I love it. That was a fantastic segue. Dr. Bhatia, welcome to the show. Thanks for joining us.
Thank you so much for having me. I'm looking forward to it.
So where should we start?
Yeah.
How about providing an overview of the current understanding of lipoprotein little a and its role in cardiovascular disease risk? What is it?
Absolutely. Sure. So lipoprotein A or LP little a or LPA, you might hear it referred to by many different names, and I just call it LPA for simplicity. But it is a lipoprotein, which basically means it carries cholesterol in the circulation. And so a lot of people have heard about LDL and HDL. It's kind of in that same family, in the same class of proteins, of lipoproteins. But there's a lot of things that make LPA unique, and I think also have contributed to the lack of recognition about it. But LPA has been established as a causal risk factor for multiple different cardiovascular diseases. It's actually most strongly associated with aortic valve disease, or something called aortic stenosis, and which I think is a very interesting segue because it might be the first medical target for aortic stenosis where none exists currently. But it's also associated with traditional buildup of cholesterol in blood vessels, things that are, the precipitating steps that lead to heart attacks and strokes. And so it's strongly associated both with heart attack and stroke. It is primarily genetically determined. So it's estimated that 80 to 90% of LPA levels are determined by genetics. And that's one gene that's in the DNA. And because of that, there's not a lot of things that we can currently do in terms of lifestyle, diet, exercise that modify it. And the levels are established from childhood. And so it's a genetic causal risk factor for heart disease. It's also extremely common to be present at elevated levels. So we don't have perfect population level estimates, but from the studies we have, at least 1 in 5 people in the world have elevated LPA. So it's very common, and it also varies by race and ethnicity.
So let's take we've got about 2 minutes left, and I think we'll continue this into the next segment. But just from like a 30,000-foot view, for a patient who's listening, and we use the term cholesterol, and in their minds, they probably think about LDL and HDL, maybe their triglycerides. So can you walk us through, like, let's say I go to my doctor, right? And I get my cholesterol readings. Yep. How should I help me interpret this? Like, what should I think about with my LDL? What should I think about with my HDL? And just kind of a general 40-something-year-old guy who doesn't have coronary artery disease, or at least that I don't know of.
Absolutely. So we know that LDL and the cholesterol that's carried on LDL are causal for the development of heart disease. But that doesn't mean everyone who has a high LDL cholesterol will develop heart disease. So it's all about understanding risk. And that's what we try to do. And there's different ways of doing that. The sort of standard method is by estimating someone's 10-year risk using a equation that was developed in large populations. And that basically takes into account things like your age and your sex and your other medical conditions and your blood pressure and cholesterol, smoking history. And then that estimates your risk. The reason we do that is we know no matter what your LDL cholesterol is, lower is better. And that's been shown in large studies that whatever someone's starting LDL cholesterol is, if we lower it, the risk goes down. The question is what your risk is to start with. So if you're starting from a low risk to begin with, then lowering your LDL cholesterol will bring the risk down, but probably not a huge benefit. Whereas if you're starting from an intermediate or higher risk group, then lowering your LDL cholesterol provides you more benefit. And so it really depends on looking at risk globally, and it can be complicated to explain because it's not just one number or two numbers. It's really looking at the whole picture.
Coming up right here on the Heart of Innovation, we're going to have more with Dr. Harpreet Bhatia with the UC San Diego Health System, and we're talking about a silent killer known as lipoprotein A, or LP(a). Don't go away. Your life could depend on it.
Leg health can indicate.
Awesome. I'm curious going into the next segment. I'd like to kind of get a greater visualization of the LP(a). So it sounds like it's a carrier. So it carries the LDL particles, just like HDL carries them. So number one. Number two is it sounds as though, so none of the regular statins, none of the regular drugs have been able to target LP(a), to be able to reduce the number of these LP little a particles that are in the blood. Right. And then
Correct.
on number three, I mean, does LPA have any value in the body at all? Is there a fear of like reducing it to the point where there's nothing?
Yeah, very good question. And the short answer is we don't know yet, but we will probably know soon with the drug trials.
And I think
Gotcha.
it's
Everyone, just going to give a heads up, 45 seconds till we're back on the radio side of things.
And I want to give a shout out to Tom, who is watching us on YouTube. Thank you, Tom, for joining us there. And thank you to our YouTube producer, Josh, for grabbing some of those comments and letting us know that there are people watching online.
Yeah, and you get the behind the scenes and actually more candid conversation. So the more the merrier.
Information.
When I grow up, I want to be just like Josh.
Nate keeps telling me off because I keep walking forward. My head keeps getting cut off. Thank you, Josh.
Okay, everyone, 10 seconds.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Thank you, everybody, for joining us. Happy Saturday. Halloween is just around the corner. I don't imagine too many people are dressing up as lipoprotein A or LDL for that matter, but two scary little molecules, right, Dr. Bhatia? And my question for you, because I think we should continue the conversation. We're learning a lot about this particle, and you've written extensively on it. So I'm assuming having a high number is bad, right? And
Correct.
we don't have a mechanism of potentially lowering it. So then is the focus of therapy to then ultimately lower the LDL as much as you can? Or I guess where would you envision some type of therapeutic vessel to kind of maybe treat this?
Absolutely. So I think as was referenced earlier, there are treatments coming hopefully in the next couple of years. So there's a lot of hope that there will be targeted therapies for LP little a. But right now we do not have medical therapies that are targeted towards it. So at the minimum, I take LP little a into account in assessing someone's risk. So like I mentioned before, if we know someone's at higher risk, then we're going to be more aggressive with how we treat all their other risk factors. So one is it can be used and incorporated into a personalized risk assessment. Two, then it can be used to guide more aggressive risk factor modification of all the things that we can modify, such as controlling blood pressure and diabetes and LDL cholesterol and encouraging people not to smoke and things like that. And there is evidence that among people with high LPA levels, if you still reduce their other risk factors, it does improve the global risk. It doesn't change the risk associated with LP little a specifically, but does improve the overall risk, which is really what matters to an individual. Beyond that, then it does guide how I treat patients. So statin therapies are the cornerstone of cardiovascular disease prevention, whether it's preventing a first event or a recurrent event. But they do not lower LP little a, so they don't address the LP little a specifically. Newer drugs like PCSK9 inhibitors, so the most common ones are evolocumab or Repatha and alirocumab or Praluent. They have, and it's not completely clear how this works, but they have been found to modestly lower LP little a, even though they were not designed for that. So somewhere in the 20 to 30% range, and it's somewhat variable in the patient response to that. But there have been some studies that suggest that doesn't seem to translate into a clinical benefit. So if I have all other things equal and I can get someone a PCSK9 inhibitor, then that's my go-to in someone with high LPA because of there may be an additional benefit in those people with high LPA. There's also a couple of other things we do in terms of antiplatelet therapy. So one of the areas we work on is in primary prevention, so preventing a first event. We have some evidence that aspirin therapy may be a benefit, even though it's sort of failed to some degree in larger clinical trials for a broader population. And analogous to that, in people who've had stents or bypass surgery or something like that in the past, there's some evidence for what we call dual antiplatelet therapy for a longer period of time. So usually after someone gets a stent in a heart artery, they'll be on aspirin and another medicine that affects the platelets, such as clopidogrel or Plavix, for up to a year. But there's some evidence that prolonging that maybe up to 3 years might be a benefit as well. So those are some of the things that I use to sort of tailor how I manage patients. And then there's some of the practical aspects too, in that we can identify families because it's genetic. So if you find one person with high LPA, we're very likely to be able to identify people in your family and sort of even target interventions with them earlier. And then there are clinical trials enrolling currently still. So practically we can potentially offer at least a clinical trial.
We actually have a patient, Nancy, who is here, and she's actually in one of those trials, and she is very concerned about her next of kin having the same issue with some grandkids that already have high cholesterol. Nancy, go ahead and unmute and share a little bit of your perspective and any questions you might have for Dr. Bhatia.
Hi, doctor. Thank you for today. It means so much to me because I've been trying to figure this out for a long time. Kym kind of got me on the lines of saying, hey, you need an advanced lipid panel. And I had a widowmaker and I had a heart attack afterwards. Luckily, there was an EMT there that saved my life. That was 10 years ago. Since then, I went and I saw there's a clinical trial with Eli Lilly. I went, I got the blood draw. I tested, my LPA was 237. They said it should be 77. I got in the trial, I qualified, I had my first injection about a month or so ago. Within less than 2 weeks after that first injection, my LDL went down 23 points from 77 down to 54, which to me tells me I'm on the medication. I'm not on the placebo. I mean, I guess my question is, why aren't we doing testing as regular blood work, as just a normal, when we go to get our blood work to get, why isn't testing for this being done to people? And then for people like my grandchildren, they are 13 and 16 years old, and both of them have very high LDL. And everybody on that one side of the family, my father died of a heart attack, my grandmother died of a heart attack, everybody in the family. So I guess I'm wondering what else can we do? And I'm taking notes on everything you're saying too.
Oh, that's a great question, and it's one of the biggest issues we face. And so thank you for sharing. And that's part of why I'm happy to be here today, is really just to raise awareness. And so hopefully we encourage more testing. We've done studies on this, and it's been done across the country as well. And typically testing rates of like less than 1% in adults have been reported for LPA. So even though 1 in 5 people might have high LPA, only 1 in 100 people is getting tested for it. So that's a big issue. I think there's a couple of different barriers. One is just, I think, knowledge, and medicine is growing increasingly complex, and there's a lot of competing things that, a primary care physician has to deal with in terms of not just looking at your lipids, but dealing with your blood pressure and your diabetes and vaccines and all the kind of preventive care that is needed. So I think it's something that's being added on. And so there's just a practical issue there that contributes to it. 2 is there's been sort of a winding road of LPA. It was actually discovered in the 60s, but it took a while for it to be proven that it causes heart disease. And there were even some initial studies that suggested it does not cause heart disease. And it ended up being related to some of the problems with the way it was measured and things like that. So I think that has set the field back, and it's sort of being revived now. But I think, to me, the biggest barrier is anything we do in medicine, we're sort of taught, if you're going to test something or you're going to send someone for, any kind of test, you want to know what you're going to do with that information. And so a lot of people think, we don't have a drug yet for high LPA, so what am I going to do with that information? And, some of the things I listed the last segment are things that we use every day to try to tailor management in people with high LPA. But I think, and we're hopeful for a drug in the next year or so, that I think that will really turn the tide. But I would wish we didn't have to wait to that point, that we could make a change earlier.
So let me ask you this. Oh, sorry, real quick.
I was going to say, I'm on the Eli Lilly trial for Lipoprotein. So I had no side effects whatsoever. I feel wonderful.
Great. Well, good to hear.
Yeah.
Harpreet, I think it's really important to expand a little bit on like who should get tested, and we'll continue this in the next segment, because you've got somebody who, so if you do their 10-year risk and it comes back at less than 7.5%, I mean, would you then consider adding a lipoprotein A on to see if it's even higher than that? Or I mean, like so this is for primary prevention. And then I think then you look at secondary prevention, people who have had coronary artery disease. And if their LDL maybe just drive their LDL as low as possible on whatever. I mean, I think so. Two separate paths of testing these folks, right?
And that's a
absolutely.
good go into our break. And we're going to have him answer that question coming up in just a moment, right here on the Heart of Innovation. Very powerful, possible life and limb saving discussion. So don't go away. More to come.
Cliffhanger.
Everyone's clear. 2 minutes till we're back.
Thank you. And I still want to, he can answer that, but I still, I want to get into, because I'm still trying to visualize like this LPA and exactly what it is.
Yeah.
I mean, I just am not quite, because I know people want this visual as patients. And how would you describe, like, maybe there's an analogy that you can give that would help to people to kind of paint the picture of what it does. I mean, is it the dump truck where, like the HDL, where it's carrying the LDLs to be excreted from the body, or what is its role?
Yeah, would say it's more like a shuttle. So it can carry cholesterol either that comes in through the diet or that's created in the liver into the circulation to different tissues and cells. And there is, a physiologic function to cholesterol that it's used for. But that's basically what LDL does, and LPA can do the same thing. And so if you picture LDL, LPA is basically LDL with an additional component to it called apolipoprotein little a, which is what gives it the name LP little a. So it's sort of very similar to LDL, but with this additional component to it, which also contributes to some of the additional ways that it causes disease.
Is there any value to it? I mean, there always is a reason why it's in our bodies.
And we think that, that's probably true, but there
Apologize
has not
for
been
interrupting
anything.
everyone. We have roughly 15 seconds till we air.
Okay, Dr. John, carry it back.
Yep, I'll bring us.
And I know Kym has a question too. This is our short one, 5 minutes.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. So before we went to break, I'd kind of posed the question to Harpreet about just, okay, let's talk about screening or getting an LPA level in a patient who you are trying to assess their risk. So if I came into your clinic and you did the risk assessment, my age, my race, my blood pressure, my cholesterol, and again, we're looking for that 10-year risk, and I came in under the percentage where you would consider putting me on a statin or maybe an aspirin, would you then, are you routinely ordering lipo A in these patients, or how do you like think about that for those that are listening? And now all of a sudden, because everybody's going to want to go to their doctor, be like, give me a lipo A, and that might not be the right thing, right?
Yeah, no, good question. And actually, I do think universal screening is the way to go for LP little a. Because it's a genetic risk factor, it's something we want to identify early and that we can intervene hopefully before an event. If we look at our American guidelines, the HAACC kind of cholesterol guidelines from 2018, they do not give a recommendation for that. They give more of a relative indication if you have a family history of heart disease, particularly at an early age, or a personal history of developing heart disease at a relatively early age, then that's a reasonable time, sort of a soft indication to check it. Since then, both multiple European societies have recommended universal testing. And the National Lipid Association, which is our big lipid body in the United States, was the first US-based society to recommend universal screening. And the Canadian Cardiovascular Society also recommended universal screening. So part of that, I think, too, is practicality. I mean, one is it's very common, and two is I think the more caveats and the more sort of criteria there are to check something, the less it's going to be done. And it's, I think, simpler to say, check it once. For the majority of people, and not for everyone, but for a lot of people, you only have to check it once because it's genetic. And then it's a blood test. It's not actually a genetic test. So it's a blood test that is cheap and simple to do and can be done in many laboratories.
And it's interesting, Kym is from Canada. Kym is calling in. Kym, ask your question.
Hi there. In Canada, the LPA is only tested once in your lifetime. Does that mean that it will never change?
It's a good question. So in the majority of people, it will not change meaningfully, meaning there is some variability, some natural variability. But if you have a low level, and we can talk about what the different levels are, but if you have a low level, it's unlikely to later go into a higher risk level. That being said, there's sort of now a newly defined intermediate range. And with people who do fall in the intermediate range, things like our National Lipid Association do recommend potentially testing again if a condition develops that could raise LPA. One of the big ones is menopause. So if a woman is tested before menopause, goes through menopause, and we're sort of on the borderline or intermediate range, I would check it again in that case. So there chronic kidney disease, hypothyroidism, or some other ones where it can be significantly changed by sort of a disease state, in addition to just some individual variability as well.
So what should a provider, let's say if you ask your primary care provider to check it, what are they supposed to do with the result?
Yeah, that's a great question. And so I think it's, where there's need for preventive cardiologists and lipidologists. And so at UCSD, at least what I tell them is check it. And if it's elevated, send them to us and we'll go through the risk assessment. We'll go through all the potential therapies and things like that. So there's an organization I work with called the Family Heart Foundation, and their website's familyheart.org. And they actually list people who have identified themselves and shown their credentials as having expertise in LPA and in familial hypercholesterolemia, another genetic cause of high cholesterol. So the goal there is that there's a directory online of specialists who even if your primary care doctor doesn't know what to do with it, that you can find someone who does.
Yeah, we'll come up next right here on the Heart of Innovation. We have another patient who's going to share her story and ask her question of Dr. Bhatia with UC San Diego Health System. Don't go away. We're clear. Just want to make sure. Yeah. So we have another caller, Dawn. So if we wanted to get to her, John, right away coming out of the gate. She's another one with LP(a). There's Dr. John.
That's me. Yeah. So I guess so in my practice, I have started checking it. And I guess for me, I know that I'm pretty good. I can get somebody on a statin, obviously, and maybe add Zetia. But I feel I send my patients to one of our lipid specialists just to kind of maybe have them on the statin and then a PCSK9 and kind of help manage that. Is that is that the right thing to do? I just honestly don't have the time sometimes to.
Absolutely. And I think lipid management is becoming more and more specialized, and especially if these new drugs come out and, there's other new drugs for cholesterol coming out, potentially we might have multiple different areas within the lipid panel that you're going to be targeting and treating. And so I think certainly we have a lipid clinic at UCSD, and one of the reasons for referral, we have sort of 5 criteria. One is high LPA. So we take all those people to our lipid clinic.
And I'd love to ask you on air at some point, ask how you would respond to someone who, there are folks that go down the statin rabbit hole and it causes this, and this.
Yeah.
And, I'd love to hear your take on what do you do for someone who's like, I'm not taking a statin.
It's a daily thing. And I have a scientific answer and a practical answer. So.
Awesome.
Yeah, because we deal with it too, and there's a whole movement of naturalists that tell people, and there are even groups, like very large groups with thousands and thousands of patients that are in them with these naturopaths telling everybody don't take statins, that there's all this evidence that says it causes all these other problems. And so it's interesting. I'm curious as well, because, you know, I tell people, well, you do you, it's between you and your doctor. And, you know, we're very careful about it. I know with my dad's situation, we ended up not doing a statin because turns out, and I don't know if it makes difference for you, but we went to Boston Heart Diagnostics and got advanced testing and found out he doesn't have a liver production problem. He has a cholesterol reabsorption problem. And the moment
Like
he started,
cytosterolemia. Yeah.
and so I think that that's kind of a big deal, but they don't check for it. I talked to a cardiologist that didn't even understand there was some sort of causal relationship between gut health and your heart. And my dad was able, I mean, he lowered his LDL particle number was lower than mine. And I was like, how in the world?
I'm
So,
guessing
and
he went on ezetimibe or Zetia, probably,
no, he
or just
just
diet.
he increased soluble fiber and went on probiotics and healed his gut and started going to, I mean, literally, I swear to God, 2 to 3 times a day. Um, so his doctors are like, wow, it's pretty amazing because he's been able to
Yeah.
slow his growth.
Yeah.
And for him that worked. And so I think some of the patients, what their issue is that they don't like to be lumped in a bucket. They like individualized therapy, and they feel like, I think, that, and we can have this discussion probably after the show, but
Mhm.
they feel as though it's just the catch-all, you know, give everybody a statin, that there's no, and I know at least for my dad, they wanted to put him on like a couple different statins, and they couldn't believe that just, you know, with his situation, with the cholesterol reabsorption issue, that he ended up, Marcia, can you mute? Thank you. So I don't
Absolutely. Yeah. I think you definitely have to figure out where people are, what their preferences are, what their beliefs are, and try to meet them where they are and figure out what's going to work for them. Because even if you force, you know, something down someone's throat, then they're just not going to take it long term. And we know, for as great as statins are, that the rate of discontinuation at 1 year is very high. So it's always a challenge too in preventive cardiology, where we're giving people medications that often are not going to make them feel better, and that's always a hard sell.
Yeah, it is with a lot of our patients.
Yeah.
And we have Carol who joined us as well. Carol, did you have a question about LP little a as well? You want to get on? I don't know if she's listening. We have quite a few people that join in. It's a very popular topic. We might have to have you come back and even just do a What's Up Doc Tuesday and just talk to patients and answer a whole barrage of questions that they have
Sure.
about just general cholesterol, which would be amazing.
Yeah, no, it's great. I'm happy to see the interest, because I think people have to, you know, unfortunately, I think people have to advocate for themselves to some degree. So
Yeah. And it's good when they come in there with the right questions. I always
right.
say it's all about asking the right questions. You don't want to go in there and tell the doctor you've been Dr. Googling everything and challenging, you know, the doctor in that way. But if you come in with the right tone and the right questions, they're usually pretty amenable.
Absolutely. I think, and a lot of times, you know, even people who don't want to be a statin for one reason or another, and I think they should be, after, you know, a few visits, I think usually we can build a relationship and then earn some trust. But you just have to work with people and you know, see where they're at.
Do you think that the insurance companies and their tiers play a role in that, forcing doctors to start at tier 1 and go through this line of statins when you know that they need to be on one that would be the third one they would try, and they're forcing your hand because, you know, of certain clinical evidence of their choosing, they have chosen that they want every single person, before you get to 3, you have to go through 1, you have to go through 2, and you have to go through 3. And I think that also is a deterrent for patients and hurting their trust.
100%. And oftentimes I tell people just the practicality of that we may have to try this and we may have to go through this, and then this is how long we give it and this is what we do, and then this will be the next step if, and I anticipate even sometimes that next steps, but absolutely, that's a big barrier.
Is there any movement in, with lipidologists to change this, or to be able to educate these insurance companies on the benefits of customizing it or personalizing it for people, and
Yeah, I
the
think
adherence to it,
right.
the adherence to the
Absolutely.
medication?
Yeah, and it's a huge. There was, a study on inclisiran, which is one of the PCSK9 inhibitors that's given every 6 months, and people do much better going on that and reaching their LDL targets because they just get a shot every 6 months and don't have to take a pill every day, which is hard to do. I think a lot of it comes from what our guidelines say, and our guidelines start with statins, and there's many reasons for that. Especially they've been around a lot longer. They're cheap and generic now, and have a lot of evidence. So the guidelines have a step up approach, and so I think insurance companies reflect that as well. And I think it has to be driven by evidence, and so there have to be more studies of using something like a PCSK9 inhibitor upfront, and then showing that that's better and why it should be used for people. But I think it is it's a heavy lift.
What was that question that you didn't get a chance to answer when we got cut off so rudely by my producer, Colin? I love Colin. I'm just messing with
I was
you,
about to
Colin.
do it again to tell you y'all got about 25 seconds.
I love you, Colin. And Don has a question, John, if you can get through. Unless you want to
Don, are you
start.
ready to go right off the bat?
Don?
Yeah, I was trying to unmute. Yeah, I have
Okay.
a question.
Okay, hold on.
Just
Hold
wait.
on, Don.
Okay, sorry
second.
to interrupt again.
Don,
We got
hold
about
on 1
3 seconds
second.
till
1
we air.
second.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Well, welcome back, everyone. We are talking with Dr. Harpreet Singh. He is with UC San Diego Health Systems down in Southern California. And we're talking about a silent killer known as lipoprotein A, or LP(a). We do have a patient who's calling in. Dawn Marie, go ahead and unmute and share your story and ask Dr. Bhatia your question about LP(a).
Hi, how you doing? Don't mind my appearance. But I wanted to know, I have LPA, it's 125. I've lost my leg to amputation. I've had a heart attack at 37, now 47. I wanted to know what your advice would be, because no doctor that I've brought my daughter to, she's not. She has LP, and hers is 119. So, she has lipoprotein. Also, and hers is 119. So if I've suffered a heart attack at 30, I think it was like 36, an amputation at 40, it was like 45, at 125, what do I expect with my 9-year-old at a level of 119?
Wow, I got chills. That's a really good question. Dr. Bhatia, have you been faced with something like this?
Yeah, no, it's a good question, and I'm obviously not a pediatric specialist, but I can give some of my thoughts. And one of the things that raises too is I wanted to just bring one brief point with LP(a). There's 2 different types of tests, and they have different units, and so there's different cutoffs for what's high and what's not. Those numbers will be high regardless, but just something to pay attention to when you're seeing the level come back as what's normal on the lab. It could be different units, so that you might see different cutoffs for high LPA. But that being said, if I had someone like you and had with the daughter who's identified to have high LPA, I tend to be on the aggressive end, where I would try to make sure that all the risk factors and things were as optimal as possible. And there is evidence for efficacy and safety of statins in children. And that's probably, a situation where, at least in adolescence, if not early adulthood, I would be thinking about putting someone on statin therapy, especially given, your history and how significant that was.
Now, where she's only 9 years old, I was told that that is too early. She'd have to wait till she was a teenager, only because, and they said this because, to be honest, their first words were to me, they don't know because they've never seen this in a pediatric child.
Right.
So that was
I think
kind of the answer I got.
Yeah, and there's definitely more people who are lipid specialists in the adult world than there are in the pediatric world, just because it's so much more common. But I think a take-home thing for LPA is, I think generally everyone should get it checked, and then if it's elevated, to try to find a lipid specialist to get sort of the most up-to-date information, and then access to things like clinical trials and so on. But I would recommend seeing a pediatric cardiologist if possible, if she hasn't seen one.
So
She
let's spend
actually has. She has. And the same thing, they say that because of development at 9 years old, they cannot treat with anything for cholesterol. Fortunately, she's in good health, and she does have great cholesterol. But I'm just nervous at what point do we have to worry about where she's high enough that she's close to me? Like, is there anything else that needs to be done other than watching diet, exercise? Is there anything more that?
Probably the biggest thing that's modifiable is lowering the other cholesterol numbers, in particular the LDL, to try to offset the risk to some degree. There have been studies in children as low as like 7 to 8 years old with statins, which haven't shown adverse effects. And so I think certainly there is evidence for statins starting at like age 8 or on. So I think you may want to see someone else who has more knowledge or expertise in it, because it sounds like the person isn't very familiar with it. But
we always say
there
to
are
people,
studies of statins.
Instead of giving up on the patient, they need to give up the patient. Find someone who is an expert if they're not an expert. Dr. John, you wanted to jump in.
My internet connection is a little bit dicey. Can you guys hear me okay?
Yes.
Okay, so that's a great question about statins, and there are a lot of folks that have some trepidation about starting statins. I think it's well documented that they reduce mortality in patients who've had cardiovascular events or at high risk. But what do you say? What do you say to somebody who's like, "Listen, I'm not taking it. I've heard bad things about it." How do you maybe change their mind a little?
Yeah, it's a great question. Super important. I think it's unfortunate. Like, I think statins are maybe the most revolutionary drugs in medicine since antibiotics. If you look at how common cardiovascular disease is, and it's the most common cause of death in the world. But that being said, I think I approach people based on where they're at, and I try to understand, what their hesitancy is coming from, what their beliefs are from, and then meet them where they are. So there are people who, if I present them with, the evidence that you mentioned, where there's evidence for mortality in addition to reducing risk of heart attacks and strokes, a lot of times they will be willing to at least try it. And I often talk about the dosing of statins and starting even at a lower dose. So the concerns that people often bring up, one is side effects. The most common of which is muscle pain, which in most people will not occur. But in people who it does occur in, it's reversible and it will go away if we stop the medication. And so I tell them, if that's an issue, there are a lot of other medications now, and there's been an explosion of therapies in lipidology where we can then move to other medications and try something else that's a non-statin potentially. But a lot of times, just practically, we have to go through at least the first step of trying a statin. Then there's been concerns raised of other things like diabetes and dementia, which I can touch on if we have time, but I'm not sure if we are getting the hook.
That's a great cliffhanger, and coming up right here on the Heart of Innovation, we're going to hear about whether or not these statins have an effect on dementia and can increase your risk of diabetes or make it worse. That's next right here on the Heart of Innovation, so don't go away.
Clear.
Okay.
Clear.
Okay. Um,
So 4 minutes left, if I read
yeah, we
that
have
correctly.
yeah, it'll be the 4 minutes to get into that. And then Dr. Bhatia, you're on the hook now. We're gonna have to have you back because we have so many questions. And do you mind sticking around for a few minutes afterwards? We have a few more questions from patients, just generally on cholesterol, if you don't mind.
Sure, no problem.
Okay, just want to make sure.
Try that on the other side.
I had a question. Does he know of any specialists for pediatrics for lipids and cholesterol? Because Virginia can't direct me anywhere.
Yeah, so so if you try going to familyheart.org, you can put in literally there's a database of specialists, and you can put in your zip code, and it'll give you whatever is the nearest specialist who's at least identified in that database. So I think that's a great place to start. And then I don't know if they do specifically mention pediatrics in there. So hopefully you can find someone, some big city. I'm sure, I don't know if you're close to DC at all, but I'm sure.
Dr.
Actually,
Lindbergh,
I think
is Dr. Nelson Lim Bernardo, does he have a lipidologist over at God, who is he with? MedStar.
yeah,
I imagine
yeah,
though
no,
that's
there are definitely people in DC.
a bit of a slippery slope though, putting a 10-year-old on a statin, and so or whatever age, but
Yeah, I mean, I think the biggest question at that age is safety.
right.
You're gonna have a higher threshold to start anyone on it. And as far as studies that have been done in children, mostly in kids with familial hypercholesterolemia, there hasn't been significant concern about safety. And a lot of the statins, so like rosuvastatin, for example, is approved for age 7 and up, but that's in
No.
familial hypercholesterolemia. And then some of the other ones like pravastatin's approved in age 8 and up. So have been FDA approved.
But those ones are for, of course, the cholesterolemia, but not necessarily
Mostly.
effective with LP little a is the issue.
Right. Effective in reducing overall risk, but not specifically the LPA. Yeah.
All right, everyone. Sorry to interrupt. 15 seconds till we air. This next segment is just mainly for Kym and Dr. John. As soon as y'all hear the music, 30 seconds until the outro promo starts talking with the outer music. All right. We're going to be live in 3, 2, 1, 0.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
We only have 4 minutes left, and clearly we have to have Dr. Bhatia on next sometime soon in the future. But let's answer those two questions that before the break: diabetes concerns and potentially dementia, starting a statin. It was my understanding that if you were pre-diabetic and you started a statin, it might shorten the time for you to become a diabetic. It doesn't make you a diabetic. Is that true?
That's exactly right. And, diabetes specialists, so the endocrinology societies, the diabetes guidelines, all say that you should still be on a statin and that is not a reason to stop a statin. And there have been some interesting studies where they show that for every case of diabetes that's caused, 5 cases of heart disease are prevented. So the net benefit is still worth it. And like you said, it doesn't take people typically from normal glucose to far off from diabetes to diabetes. It's more people right on the border. It might shorten the time to development. Yeah.
What about dementia?
But they could actually, but I just want to mention, but they could actually change their lifestyle, eat better, exercise more, and maybe they wouldn't have the issue.
Absolutely. And all that's, of course, extremely important. And we often forget to mention those things. And then in terms of dementia, there has essentially been debunked where there have been large studies where they do cognitive assessments with people before starting a statin and then on a statin have shown no difference compared to placebo. And statins do actually, to some degree, prevent dementia because they reduce the risk of strokes, which is an important cause of vascular dementia. So that I try to explain to people has basically been refuted.
And in the last few seconds that we have, what are some of the key challenges or barriers to widespread adoption of universal LP(a) screening, and how can we address them? We have only about 30 seconds.
Absolutely. I think it's knowledge. I think it's having more clear guidelines, and then having something clear guidance on what to do if someone has a high LPA level. And so I think in the next couple of years, we're going to see a lot of change in all those areas.
Thank you so much,
Amazing.
Dr. Harpreet Bhatia with UC San Diego Health System. We really appreciate you being here. And what's that website if people want to find out more about LP(a)?
Yeah, familyheart.org. It's a great resource for patients.
Thank you, everyone, for joining us. I hope you have a great weekend.
Thanks, everybody.
I think we're clear. We're going to have to work on that.
All right. Yep.
That was awesome. Thank you so much. Do you mind if we get in a few questions? We have quite the studio audience today. So let's go ahead and Marcia, unmute and ask Dr. Bhatia your question.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kym.
Well, I said Marcia, but you know. Marcia, go ahead. She might have walked away.
There we go. No,
There we
I
go.
couldn't find it. I'm on my phone. Sorry.
That's okay.
Yeah, my question isn't about LP little a. It is not, but I was wondering about if you've done a good job. Like I've been on cholesterol medicine my whole life, well, my adult life, and it was still very high, but I finally changed my lifestyle, and now I'm like so good, it's ridiculous, and I'm still on medicine. How do you feel about a patient going off medicine when they've really managed their levels, through the right means?
Absolutely. Great question. So I think it has to be individualized, and I certainly talk to patients about that, and depends on what your numbers look like, what your overall risk looks like. And it varies a lot in how much lifestyle can, change cholesterol and things like that. A lot of the cholesterol that's circulating in your body is actually synthesized by your own cells, created by your body, and a smaller portion is from diet. But obviously with lifestyle changes, with weight loss, with the advent of new medications for weight loss, that is probably going to change to some degree. So I think it has to be individualized, but I say that it's not always something that's forever, unless if someone's had a prior heart attack or stroke, then you just put yourself into, unfortunately, a much higher risk group, where those people, I say you should be on this forever, but we may be able to reduce the dose. If there's side effects, we can always work with that. So I think that it doesn't have to be an absolute necessarily.
Thank you.
It's interesting because I'll have patients who will say, hey, my numbers look good. I want to stop it. And I'm like, well, your numbers look good because you're on a statin. So I have to, if you stop it, they're probably going to go up. But
right, they don't cure it. Yeah.
Yeah.
Dr. John, like my numbers were so high. I mean, I was a heart attack waiting to happen. And I've been on medicine all this time. It wasn't until I got P.A.D. and had diagnosis and pain that I woke up and realized I've got to change things. So, I mean, even on the medicines, I was, I was a heart attack waiting to happen. I certainly was.
Yeah, I think both aspects are definitely important. And, something people sometimes ask is there an LDL that's too low? And I haven't found one. And so I do not necessarily reduce people's medication just because the LDL is low. I just say, hey, you're at lower risk, and if you're tolerating the medication, fine. I typically continue it. But sometimes people say, oh, if I'm on 2, can I go to 1 or something like that? And I'm certainly open to that. We always recheck and see where it goes to after, to make sure you're not going up too much.
What are your thoughts?
Go ahead.
No, I was just going to say, what are your thoughts on HDL? And so it was always kind of my thought process, and maybe I'm wrong, but I'd rather have a high HDL and a higher LDL than a low LDL and a low HDL. Um, any thought? I mean, so number one, I tell my patients, like, you got exercise brings your HDL up. We don't have a medication really for it yet. Maybe we will. Um, are you someone who, let's say they come in with an HDL of 41, which is low-ish, or let's say 30, but their LDL is maybe less than 100. How do you approach that? Would you put them on a statin of some sort just to kind of lower the LDL because the HDL is low too?
Yeah, it's a good question. And again, it's all part of looking at it holistically. So if we look at people's kind of global risk, what their HDL is factors into that as a risk factor. So low HDL certainly is a risk factor. But if they're young and otherwise low risk, it may not be enough to kind of put them in that, higher risk category where we would put them on therapy, especially with an LDL around 100 or less. But say someone's older and might have diabetes or high blood pressure, something like that, the HDL is certainly a factor in their risk assessment. So I think I look at it globally. I wouldn't do it just based on the HDL alone. It's sort of more part of the comprehensive risk assessment.
Yeah, we get asked questions a lot about the HDL and people's concern that with the
Yeah.
statins, they lower both the LDL and the HDL. But what they say to me is, well, don't you need that HDL higher in order to carry those LDLs out? So aren't we doing more harm than good?
Yeah, it's a great question. I think, and this is one of the fascinating things about clinical research and science is that we have to always test these things out and see what happens. And that's why we do clinical trials. So we've known for a long time that low HDL is a risk factor for heart disease. But several drugs that have raised HDL have failed to improve outcomes. We've seen something similar with triglycerides, where we know people who have high triglycerides are at increased risk, but several drugs that lower triglycerides have not improved cardiovascular outcomes. So it really, I think at the end of the day, numbers are important, and they're very useful, and it's I think very attractive to look at numbers and target numbers and kind of think about it that way. But really, at the end of the day, what you care about is what's your risk for a heart attack or stroke. And so we look at it more, if we put someone on a statin, we know it's going to reduce that risk, whatever the effect on HDL may be. There's even some evidence, which is, I'd say, not clearly established yet. And so we don't really understand it fully, where people with very high HDLs actually have an increased association with risk as well. So sort of the low end and the very high end seem to have increased risks. Not fully understood yet, and I think not ready for prime time, but I think it's still an evolving field. Even though we've known some of this forever, we don't really understand everything.
And we have Ava that has a question. Ava, go ahead and unmute and ask the doctor your question.
Hi, good. Thank you for having me. And Kym, thank you so much for introducing me to Dr. Khatib. I am thoroughly grateful. My question is, which of the statins do not have the potential to cause diabetes? I've been on rosuvastatin and Zetia for years, and I've been diagnosed as pre-diabetic.
Yeah, so it tends to be more common with higher potency statins and with
I'm on 10 milligrams and 5 milligrams. I'm sorry, I didn't mean to interrupt.
No problem. And with higher doses of statin. So that dose of rosuvastatin is a moderate intensity statin, and 20 or to 40 is sort of the high intensity statin dose of rosuvastatin. Okay. I think what's hard in an individual is to really say it was the statin or not. It's hard to really, prove that. We know on a population level, it does increase the risk to a small degree. That being said, whichever statins, the higher potency statins are the ones that are the most beneficial as well. Right. So it's sort of looking at the risk and the benefit of it, and it still seems to be a net benefit.
Okay, yeah, because I've had high cholesterol, high triglycerides my whole entire life, upwards of, both of them being upwards of 400 and 500, right. 600. And I am also LP(a), which is at 161.
Right. Absolutely. So your risk obviously, is increased by all those different risk factors, where the net benefit of a statin is going to be greater than the risk for you. I would think, yeah.
And we have Nancy and Marcia. So Nancy, go ahead and unmute and ask your question.
Okay, I'm allergic to statins, so I've been on Repatha for a few years, and I do see a lipidologist,
Okay.
and she's with my cardiologist, and I've done very well with Repatha, and it has brought my numbers down. It just didn't bring it down far enough. It only brought my LDL down to 77, and since I had a heart attack, they want it down around 50, and hopefully it's going to go lower. So is it just as good as the statins? Am I going to be okay just taking Repatha? And I take
Yes. Very good question. They have not been compared head to head. So that's sort of one caveat to what I'm about to say. All the trials of PCSK9 inhibitors like Repatha are done on top of a maximally tolerated statin. So technically, that's how the evidence at least has been generated. That being said, there was a time where we thought there was something about the statins beyond just the LDL lowering that improved risk. Now with newer drugs and looking at how much they reduce LDL and how that translates into benefit, it seems to translate similarly to statins. So I think generally it appears to be just about the LDL lowering rather than one specific drug or another. So I think there's different ways to get there. And so if you get there with Repatha versus a statin, that's great. I tend to think of them similarly. Repatha is actually more potent in terms of lowering LDL than a statin is. And so it is actually potentially of greater benefit, especially if you can't tolerate a statin. It's a great option.
Okay, great. And I get it through MUSC free of charge, and that makes a huge difference because it is very expensive, and that's a problem for so many people.
Absolutely, and that has gotten better, but there's still issues. Absolutely.
Thank you.
And I should have checked this before because I can't remember the name, but we were talking to Dr. Parag Doshi, an interventional cardiologist out of Chicago, when I was there a few months ago, and he was mentioning that there might be a once a year cholesterol drug, that possible injection that is looming, that's being worked on right now. Have you heard anything in the works on this?
Yeah, so there are drugs being developed that could be once a year, and there's even people evaluating gene editing approaches where it would be once in a lifetime. Obviously, that would be for likely a selected group of people, but there's a movement towards that. And something that's already available is a drug called inclisiran, and the brand name is Leqvio. And it's an every 6-month injection that on average lowers LDL between 50 to 60%. The biggest issue has been expense and insurance coverage thus far, but it is getting better. And so that's something that's an option, especially if, it's challenging to inject yourself, say every 2 weeks, or, taking a pill every day. This is something where you go to a clinic or an infusion center every 6 months and get an injection, and then the drug sustains its effect for that period of time. So there's I think a lot of new things, a lot of exciting new things on the horizon.
Oh, fantastic. And back to my one question, and then unless Dr. John has more additional questions.
I've got one more
for you,
question. I've got one more question.
Okay. Can I ask just the one that because I think this is the one that got cut off and I can't remember, about the benefits of like these LP little a has to have some sort of value in the body. Do we know what value it actually provides?
We don't. We don't, and we it's presumed that there's some evolutionary advantage to it or something, but that has not been identified yet in any studies. There is some evidence that if people have very low LPA levels, that they might have increased risk of diabetes. I think that we're going to get the answer to that soon with these new drugs that lower LPA 80+%. We'll see if there does seem to be an increased signal for diabetes. There's also evidence, sort of, I'd say somewhat mixed evidence, but there is evidence that LP little a is what we call anti-fibrinolytic, which means it when someone develops a clot, it decreases the body's ability to break down that clot, which could be advantageous in the setting of something like bleeding. So if someone has a propensity for bleeding and then they clot, LP little a would kind of be pro-clotting. That's sort of, I'm reaching here on potential explanations, but that's one. But at least so far with looking at the new drugs, they haven't increased bleeding risk thus far. So that hasn't really panned out clinically. So I wish I had a better answer, but I think unfortunately we're gonna have to wait to just see if there's any adverse outcomes from the trials. So far, there hasn't been much suggestion of it.
And Dr. John?
Yeah, I'm curious, have we kind of cornered the market on our understanding of lipids and all the particles, or do you foresee something else out there that, we're going to discover that potentially cures or prevents, plaque development, atherosclerosis?
Yeah, no, I think there's still a lot to learn and a lot to develop. One example I give a lot is if you look at a drug like evolocumab or Repatha, and you look at the clinical trial that they did over about 3 to 4 years of follow-up, they took people's LDLs on average from 90 to 30, so significant lowering of LDL. Still, like 11% of people had an adverse outcome compared to like 13 or 14% in the placebo group. So there's still something else there. It's not just LDL, whether it's inflammation and how that plays a role, and specifically what inflammatory target. I think LPA plays a role. Triglycerides is sort of an area that has been revived, had kind of died where multiple drugs had failed that lowered triglycerides and didn't improve outcomes on top of a statin. And there's newer drugs with different mechanisms. And then beyond that, then there's other lipid-lowering drugs with newer mechanisms that are being studied in people with heterozygous familial hypercholesterolemia. So I think cholesterol metabolism and transport is very complex. There's a lot of different steps. And because of that, there's a lot of potential targets. So I think this is still a field where it's going to continue to evolve. And because of how important it is and number one killer of people in the world, that interest in, interest both from a physician patient standpoint, but also from an industry standpoint, I don't think is going to go away. Gene editing, is something that's going to be probably many years away, but something that is very attractive for something like LPA, where we know it's caused by one gene. If you could silence that gene with a gene editing drug and identify someone at a relatively young age, you could theoretically prevent any adverse outcomes related to LPA at least. And so that's something that's seen, especially if we don't identify a physiologic importance for LPA.
It's interesting.
Yeah. No, I was just going to say, just there's so much more to learn. It's interesting.
Yeah. But why are doctors, when 40% of people who suffer a heart attack have normal cholesterol and a basic lipid panel, why are we so reliant upon this basic lipid panel? Why are we not just going the extra mile, especially for those who have additional risk factors, especially with family, genetic risk factors, that they would do an advanced lipid panel where we would be able to see the LDL, the particle number even? Because I know it was a big deal with my dad. The reason that my dad's primary care doctor was not going to send him to a cardiologist was because he wasn't at risk of a heart attack because he had normal cholesterol and a basic lipid panel. And so she said she didn't have a diagnosis code. And I said, I have a credit card that says you don't need one. So let's go ahead and let's start with the ECG.
Yeah.
And behold, there was an abnormality. And then they put him did a nuclear stress test, further issues. And of course, he was on the table on the verge of a heart attack and he needed to have his arteries opened up. And so how can we stop this? I see the value of doing an advanced lipid panel because of what happened with my dad, but yet most doctors do not.
Yeah, and I think some of it is just the practical way of how medicine is conducted, and there's an emphasis on evidence base. So there has to be, for something to make it into guidelines, there has to be a high level of evidence showing the benefit to it from typically from clinical trials or something analogous to that. And so and a lot of people, especially people who don't specialize in an area, practice off of guidelines, and that's also what insurance companies kind of reflect. And so that's not something that's in our guidelines as of yet, unless it's more in a sort of targeted way. And it sort of brings up not something that relates specifically to lipids, but just the idea of that we don't have great screening tools, I think, in prevention of cardiovascular disease. And I think that's sort of the holy grail of preventing heart disease. Whereas, we do things to screen for cancer and other things that are actually less common than heart disease. And right now we're relying on sort of large population-based equations, which do a good job on a population level if you're looking at thousands of people, but for the individual person, it's not perfect. And so that brings up something like calcium scoring, which is a potential tool that we do use for screening in people. And everyone will have a case of someone who you're surprised that they have some coronary calcium and have evidence of plaque buildup despite not having other traditional risk factors, something like that. So I think it's something that just there has to be a shift, hopefully, in the field of understanding, a better way to systematically screen people across our population.
And I'm not a cardiologist. I'm only going just based on logic with my experience with my dad. I mean, if you have, so you have a normal basic lipid panel, you go have the advanced lipid panel, and he has a large number of these small LDL particles. The way that his cardiologist explained it to me, that when they become oxidized by the trans fats and free radicals, that those are the ones that are the greatest troublemakers. Would love to hear your story, but I think that that's evidence in and of itself. I've even been considering going on a statin, even though I have normal cholesterol, simply because my LDL particles, I have a lot of small ones, they're elevated. And so for me, knowing my family history, even though it's a later onset in my family, I still think that it might be an option for me.
Absolutely. And again, that's why I think I tend to stay away from words like normal cholesterol. Because I don't think there really is a level that's normal. The people who their names Brown and Goldstein, who actually discovered like the LDL receptor mutation and discovered familial hypercholesterolemia. Essentially, they had postulated that for sort of normal cellular function and things like that, people might need an LDL around 25. So that's probably the closest to normal that I would say. I've definitely, absolutely, I've seen people with heart attacks with LDLs that would be considered normal, by a lab. But oftentimes lab tests are defining normal by just a population level. So if you're below, 80% of people have a level sort of below a certain level, that might be considered normal. So really, it comes back to risk. And if someone's at elevated risk, whatever your LDL is, whether it's 50 or whether it's 150, lowering it does reduce the risk. So if your risk is high, it should be, and that's what we need to be able to better identify as the higher risk. And I should note, LPA is one of those things where you can have a normal lipid panel, or at least in quotes normal, but the LPA is high, and so that's why something like universal screening makes sense, because there's not always a signal of some person who should be checked, even though we have some relative ideas of people with family history and things should have it checked, but it could be something just hiding that we don't have other indicators for.
Yeah, and to your point too, like the practicality of getting all these particles tested, and half the docs don't even know what to do with this stuff. And I think that's what's interesting about the field. Like it's going to continue to evolve, and we'll get smarter thanks to the research that you're doing about, okay, how do we screen these folks and treat them appropriately?
Yeah,
awesome.
and
Awesome. Yeah.
That's why just related to that, LDL particle is one way of doing it, but ApoB is another thing analogous to LDL that is actually a better representative marker than LDL, and it's analogous to LDL particle number, and I think part of it is, and our lipid society now recommends ApoB over LDL, but I think part of it is just inertia, and we've been doing things the same way for a long time. It's very hard to change, and that's why it comes from a big public policy level or from a guideline level, where that's the only way that I think large scale change really happens.
So you could have a high ApoB and what we would consider normal, cholesterol in the basic lipid panel, even though you don't like normal, and the ApoB is what you prefer to look at.
Right. So it's the majority of people will have what we call as concordance, where the ApoB lines up with the LDL cholesterol. But in a not small minority of people, they can be discordant. So ApoB is a better measure. It tends to be the most useful in people with high triglycerides for a couple of different reasons. But it is overall just a better marker.
Can you just quickly, just as we close out here, go through the markers just really quick? So if people, are like, I don't understand cholesterol, you have HDL, you have LDL, you have ApoA, ApoB, you have LP little a, you have LDL, you have large fluffy ones, you have small, dense, LDL particles. Like, holy Moses. Can you just do a quick sorting it out in a basic level so people kind of understand and can visualize it?
Absolutely. So there's, the standard lipid panel where you get your total cholesterol number, which is basically adding up all the cholesterol that's measured in your circulation. You have LDL, which one of the interesting things about LDL cholesterol, the way it's reported on lipid panels, is it's actually calculated. So you basically take the total cholesterol and subtract everything else from it. And then the LDL is what's left over. So it's actually not, that's part of why it's not a perfect measure. LDL cholesterol, what's reported on a panel and says LDL, is really the amount of cholesterol carried on LDL, which is not as good a marker as LDL particle number or apolipoprotein B, which are actually measuring the number of particles that you have. So you can have, for various reasons, variation in how much cholesterol is carried on the particles. It's actually a better predictor to know how many particles you have. And then LPA is not even in that, any of that standard panel. One of the other nuances of LPA is that LPA carries cholesterol, and some portion of the cholesterol that's on LPA is included in the LDL cholesterol measurement. Since it's not actually measuring LDL cholesterol, it's subtracting HDL and triglycerides from total cholesterol. So what's left over is assumed to be LDL, but actually also includes LPA cholesterol. And so I think it was Nancy who mentioned that, or I forget if it was Nancy, someone who mentioned they went on an LPA lowering drug trial potentially, and their LDL actually went down. And the drugs actually, we don't anticipate they would lower LDL very much, but they're probably lowering the LPA cholesterol portion of LDL in someone who has high LPA. So that, I don't know if that clears it up very much. And then there's HDL, which does what we call reverse cholesterol transport, which is basically taking cholesterol out of the circulation, helping to get rid of it. So it's thought of as a beneficial thing, as a good thing. And colloquially called the good cholesterol, LDL colloquially called the bad cholesterol. But really, we think of all cholesterol as really bad. It's just the carriers of them may be good or bad and what they're doing with the cholesterol.
Fantastic. Thank
Easy
you
as
so
mud.
much.
Or clear as mud, right?
Yeah, exactly. And Kym just wants to know about if you should be on a blood thinner if you're on a statin, but that just really depends on the person.
Absolutely. So by itself, a blood thinner, it depends on what you mean by blood thinner. So there's not a strict indication based on just being on a statin. If people have had strokes or heart disease or things in the past, you may be talking about something like aspirin or a stronger blood thinner. And then in prevention of heart disease, for the most part, we've moved away from using aspirin in prevention. Although we think there are high-risk individuals who may benefit from aspirin, such as people with very high calcium scores, or people with high LPA may benefit from aspirin. So it really depends on the situation.
Fantastic. Thank you so much, Doctor. We really, really appreciate you being here, and we would love
Thank you very
to
much.
have you back. So anytime you have any new information, new research, anything, consider this an open invitation because this is fascinating. We really appreciate from the bottom of my heart, on behalf of all 12,000 patients that we support across the globe, thank you for all you are doing to help save life and limb.
Well, thank you. It was great. That flew by, so it was fun.
That's awesome.